No, thank you so much. Very interesting case. We'll go to our next case, Unseen Threat by Dr. Akash Kumar from Medicine 1.
Good morning, everyone. I'm presenting on behalf of Medicine One. My topic today is unseen threat. So the case presentation is: he's a 45 years old gentleman. He's a barber from Andhra Pradesh. Had presented with chief complaints of fever for 7 days, productive cough for 4 days, and worsening breathlessness for 2 days. So actually was apparently well before 7 days when he developed this moderate grade continuous fever with chills and no diurnal variation. With fever, other than that, he also had cough, which was productive, non-foul smelling, mucoid and yellowish white in color. He also started developing worsening breathlessness, which progressed from MMRC grade 1 to 4 in the past in 3 days. Other than that, for fever, he did not have any other localizing signs like jaundice, abdominal pain, loose stools, altered sensorium, seizures, or urinary complaints. With the worsening breathlessness, he had no history of chest pain or palpitations. Initially, was evaluated elsewhere. He was started on NIV. He was NIV non-tolerant, and he was intubated elsewhere in view of worsening respiratory distress. He was brought to us for further evaluation. Past history-wise, he had nil comorbidities. There is no past history of pulmonary tuberculosis. He is a non-smoker, and there is no history of obstructive airway disease or an inhaler usage. So, on arrival to ED, actually, sorry, sir.
Any high-risk behavior?
No, sir.
How long was this?
Only a week, sir. Fever for 7 days with worsening breathlessness and concurrent productive.
Some more. You look at any CPC, you see the kind of because this is 45-year-old man getting an pneumonia and being intubated. So it's all sorts of exposures you have to ask for birds.
Yes, sir. So on examination on arrival to ED, he came intubated, not have any pallor icterus cyanosis, clubbing or lymphadenopathy. But arrival to ED, his blood pressure was non-recordable, so he was initially started on inotropes. His respiratory rate while being on ventilator is 19 per minute. He was tachycardic with a heart rate of 124 per minute. He maintained a saturation of 90%. Systemic examination wise, respiratory system, he had normal vesicular breath sounds heard bilaterally, and there is bilateral scattered inspiratory forced crepitations right over the left side, and there is scattered inspiratory wheeze also. Cardiovascular system examination, S1, S2 heard, and there are no murmurs and no LVS3. And per abdomen, there is soft, non-tender, and no organomegaly. CNS bilateral pupils were reactive, and gag reflex is present, and ankle jerks were absent. To summarize, so this is a 45 years old gentleman. He had nil known comorbidities, had present with the acute history of fever with productive cough and worsening breathlessness, and on clinical examination, he had bilateral scattered crepitations and wheeze. So syndrome we considered as an acute respiratory distress syndrome. So differentially considered as probably he has gotten community acquired pneumonia secondary to a bacterial or viral infection, or other arboviral or rickettsial infections like dengue with ARDS or scrub with ARDS we consider, or sepsis from some other foci causing sepsis induced ARDS, where the first prime differentials we considered of.
He also had septic shock.
Yes, sir, he was on septic shock. So on initial blood investigation, we had an normal hemoglobin and platelet count, and he had an total counts of he had a leukocytosis with left shift and toxic changes. He had an acute renal dysfunction with a urea of 159 and creatinine of 2.84, and his liver parameters were also deranged. He had an LFT of 1.13 and total bilirubin of 1.13 and direct of 1.00. SGOT and SGPT were also elevated with an elevated alkaline phosphatase. And ECG showed sinus tachycardia. Urine routine showed 1 plus proteinuria, but RBC was 52 per high power field, but he was also catheterized at that moment. So he had a very high heart rate. So also did a CKB dropty to rule out any underlying myocarditis, which showed an first set is 8.8, followed by the second set of 6.5, and dropty is 960, followed by second set of 579. And also had an CPK of 3196, and which subsequently got increased to 8068, and had a very high procalcitonin of 398. So we did an X-ray. So X-ray showed he had a right-sided predominant inhomogeneous scattered opacities were found. So following which we did the workup for fever. So initially we said the AUFI workup which were negative, and other workup we sent the ET culture sputum, culture sputum which didn't show anything, and sputum expert and MG were sent which did not MTB was not detected. Said the subsequent of blood cultures, one of the blood cultures group Burkholderia pseudomallei. Meanwhile, we also sent multiplex PCR which also had para-influenza was detected. And during this, so we also evaluated for him. So he had an HbA1c of 12. He was a newly diagnosed diabetic after coming to us. So this Burkholderia, in view of this Burkholderia pseudomallei, was initially started on meropenem, an antibiotic assay it is sensitive to. So the final diagnosis for him is he came with acute septicemic pneumonic melioidosis, pulmonary involvement with bacteremia, with concurrent para-influenza infection. He came with severe sepsis with septic shock and multi-organ dysfunction. He had an acute renal dysfunction, acute liver injury, and also we considered the rhabdomyolysis secondary to severe sepsis. And he was newly diagnosed with diabetes mellitus. So here I wanted to put a short note about this acute septicemic pneumonic melioidosis. So we all know melioidosis is an endemic infection in India. It is associated with high mortality as well as morbidity. It is an facultative, it's an intracellular NFGN, non-fermenting gram-negative bacterium. So endemic regions, if we consider it, is most commonly endemic to Northern Australia, China, Southeast Asia, which means India, Bangladesh, and Sri Lanka. So actually, these are environmental organisms. They are found normally in soil and water, especially in those endemic regions. So whenever they get so the infection predominantly is by inhalation, aerosolization, ingestion, or they enter inside by abrasion. This like inoculation via contact through open wounds with contaminated soil, dust particles, or water. So in India, as I said earlier, so northern Australia and Southeast Asia is considered as endemic regions for Burkholderia melioidosis. And in India, actually, Tamil Nadu, Andhra Pradesh, West Bengal, and this is from our data, CMC data. So Tamil Nadu, West Bengal, and Jharkhand and Andhra Pradesh have high cases documented for melioidosis. So the risk factors we considered is, so most of this is our study which is done, which showed an average age of, it's predominantly male predominance, and main comorbid conditions most of them have is they are a diabetes mellitus, uncontrolled diabetes mellitus, and they have a ethanol consumption, and some of them can have sickle cell disease, chronic kidney disease. These are considered as the risk factors for melioidosis. And organ involvement is predominantly the most common organ involvement is lung. And if there is a septicemia, the primary main source of infection will be predominantly from the lung. So other than that, predictors of mortality is if a patient is coming with pulmonary melioidosis. So if a patient has gotten tachypnea, if a patient has got a severe tachycardia, the patient has got bacteremia, and if the patient requires ICU admission and mechanical ventilation, they are poor predictors of mortality. So pulmonary manifestation, how they can present is there are three forms. Either they can present as an acute and subacute and as a chronic presentation, which can mimic as tuberculosis. So if you see an acute presentation, so they can have just a consolidation, they can have nodular opacities. It can range up to even they can form thin-walled capacities. And especially if we see Burkholderia, usually they have predilection for the upper lobes. So especially if you see acute septicemic pneumonia, they have predilection for the upper lobe. But in non-septicemic, there are other case reports are also there which show there's lower lobe involvement, but predilection is more for the upper lobe. So as I said earlier, they can present like nodular opacities. They can even present like a thin-walled cavitatory lesions with or without consolidation. And if there is a subacute or chronic melioidosis, there will be a gradual presentation, and they can mimic tuberculosis. So pleural effusion wise, actually it is uncommon in melioidosis, but if it's a lower lobe disease, they can have pleural effusion. In rare cases, they can also present as an emphysema. So acute presentation will be, usually they have an incubation period of 2 to 5 days. Imaging will show unilobar or multilobar infiltrates, predominantly upper lobes, and they can have nodular lesions. Subacute and chronic will be a slow and gradual progression will be there, mimicking TB. They can have cavity formation too, and in them also upper lobe is predominant. And some of the cases they can have subclinical presentation too. So the treatment predominantly all we know, actually it's an intensive phase and eradication phase. Intensive phase we predominantly choose meropenem or ceftazidime. for 10 to 14 days. But there is a revised criteria now. So what they suggest is, so if a patient has a concurrent bacteremia and a pneumonia of only one single lobe, or if they have a unilateral or bilateral multilobar pneumonia without bacteremia, the intensive phase has to be given for 3 weeks. Whereas with concurrent bacteremia, and if they have unilateral and bilateral multilobar pneumonia, they have to be treated for a minimum of 4 weeks for the intensive phase. Our patient actually had a concurrent bacteremia and unilateral and bilateral multilobar pneumonia. Hence, he was planned for a total of 4 weeks. And if a patient is severely septicemic, and if it is for a CNS involvement, meropenem is chosen always when compared to the ceftazidime. The eradication phase actually can most commonly preferred is oral trimethoprim sulfamethoxazole, minimum of 3 to 6 months. Other option will be amoxiclav. So outcome of patients are treated with meropenem is, so this is one of the study which shows outcome of patients with melioidosis treated with meropenem. So in this study, actually there is a selection bias. What they did is they selected some patients which are previously some were given ceftazidime and some were given meropenem. So in this group, around 154 patients, and there is some patient who relapsed. So totally 165 patients were given ceftazidime, and other meropenem, if they went back, around 68 people received meropenem. But if we see the meropenem patients who were given meropenem were given they were very sick patients. They have high proportion of very sick patients, and whereas ceftazidime group, they are clinically actually stable patients. So when comparing to that, actually meropenem, even when given to a very sick patient, it has a mortality of better mortality benefit of 25% when compared to the ceftazidime. It is 76%. So drug monitoring is also very important. So antimicrobial therapy, if you are starting with a meropenem, even it may not yield the desired response despite adhering to standardized dosage regimens, and especially in critical ill patients because of fluctuations in meropenem pharmacokinetics. So if a critical ill patient is there, keeping a target concentration of 5 times above the MIC of the organism may improve the clinical outcome. So in our patient also, initially after starting with appropriate antibiotic of meropenem, he continued to have high spiking fever. So we did the meropenem trough level, which was low. Then we gave gave him a continuous meropenem infusion for 8 hours, following which actually he responded. So our patient, I said earlier, clinically improved. He responded. He became afebrile. He was extubated and weaned to room. His blood culture also cleared on 29/11/24. He was planned to be treated with IV meropenem for 4 weeks. As I said earlier, he has a multilobar involvement with concurrent bacteremia, and with an eradication phase of cotrimoxazole for 3 months, along with tight glycemic control. So the learning points here is challenges in management of melioidosis. It has high mortality rate. Sometimes there is some delay in diagnosis because it mimics TB, and there is a chance of resistance, and people also require prolonged duration of therapy. It masquerades as other common pulmonary infections like other pneumonia and tuberculosis. So if in an endemic area, or if a patient has uncontrolled diabetic, so if a patient comes with community acquired pneumonia, we should consider as an acute septicemic pneumonic melioidosis as also as one of our differential is one of my learning point in this. Thank you.
Thank you, Akash, for the presentations. Any questions? Yes.
Very nice case and presentation. Just out of curiosity, how many cases does the medicine unit see in a year?
What's the statistics?
Melioidosis, sir.
How many cases were there in that paper by general medicine? Was that paper you quoted or some general medicine?
Sir.
114 cases.
Yes.
This is how many years?
It's only from medical units, I presume. All the doctors are from medicine.
Yeah, usually it will be medicine. I'm not sure this is 1 year or is it 1 year?
Yes, sir.
This is long way.
Hmm.
I'm not sure. Often, maybe say if we look at 1 unit, you may be saying maybe 5, 10 in a year. Not very common, but you do see.
Sorry, sir. Occupation. Barber, sir. Barber.
Sorry? That series, sir? 6 years? That's what, so, 20. 26 years.
Just keeping to time, keep it within
No,
10
there's one
minutes.
more question I had, that PCR, are they doing a PCR now? You
Yes,
said
sir.
PCR was positive.
Yes, sir.
Doesn't matter. PCR was positive. And
Para-influenza, sir.
you said PCR positive for
Influenza.
Yes, sir.
There was confirming the diagnosis of biochemical test. Now they're doing PCR. They are doing PCR. Yes, sir. But we cannot force it to order stand up when it is done. The blood culture, the blood culture.
Thanks, Akash. We'll go to the next presentation. A stitching time does not save nine. Dr. Namrata from Medicine 5.
Good morning. I'm Namrata.